Walk into almost any general practice today, and you'll see the exact same structural logjam. Patient wait times are stretching out for weeks, while administrative tasks pile up behind the front desk. Part of this bottleneck exists because highly trained doctors spend hours every week managing routine tasks, like reissuing an oral contraceptive prescription or approving a request for emergency contraception. Just down the street, local community pharmacies sit with empty private consultation rooms and skilled clinical staff ready to help. But because these two systems have historically operated in isolated silos, the pharmacy lacks a steady, reliable pipeline of patients. Solving the GP waitlist crisis depends on building a functional pipeline between these two resources, rather than solely focusing on recruitment. In the UK, the healthcare system is forcing this integration through an active incentive scheme known as Target 6. The core mandate requires GP teams to build a two-way referral pathway connecting to local pharmacies. For the NHS Pharmacy Contraception Service, this splits into 3 clinical lanes: starting the pill, ongoing supply, and emergency contraception. This formal pathway integrates the community pharmacy into the GP's core clinical team. The first practical step toward integration relies on the pharmacy making the opening move. They must proactively reach out to the practice manager or prescribing lead at the GP clinic. They do this by providing a simple one-page summary letter like this one. It confirms exactly what clinical services the pharmacy handles, details their consultation room availability, and establishes a direct line of contact for the GP staff. The entire objective of this initial meeting is clarity. By mapping out exact operating hours and walk-in capacities, the GP gains the confidence required to route their patients to an external partner. That initial handshake secures the necessary trust before a single patient is ever diverted. Once that trust is established, the action moves to the GP reception desk. Here, the receptionist shifts from a waiting room gatekeeper into a strategic care navigator. Triage staff use a 15-second screening tool to categorize contraception requests. The green light path instantly signposts routine repeats, first-time starts, and emergency contraception directly to the pharmacy. The red flag path keeps implant requests, severe pain, and complex histories strictly with the GP. Establishing these clinical boundaries makes delegation safe. GPs delegate routine requests because they know complex cases are strictly protected. To physically move the eligible patients without adding administrative drag, practices use automated text messaging systems like Accurex. If a patient calls asking for a routine repeat, the receptionist triggers an on-demand response. While still on the phone, they text the patient a direct link to a local pharmacy finder. Practices also run proactive batch campaigns. They pull a list of eligible patients due for an upcoming review and text them an invitation to walk straight into a pharmacy, bypassing the GP booking system entirely. By digitizing the referral, the clinic avoids endless phone tag and places healthcare access directly into the patient's hands. There is one final hurdle to making this work: the fear that sending patients off-site will lead to fragmented medical records and lost data. Inside the pharmacy consultation room, the pharmacist conducts a full clinical review. They check blood pressure, calculate BMI, and verify overall clinical suitability. Here is the technological closed loop. Upon patient consent, a digital summary notification is securely transmitted from the pharmacy software back to the GP system, where it automatically attaches to the patient's electronic medical record. The patient's record stays current, and the GP practice staff do zero manual data entry. Observe the rewired primary care ecosystem operating at full efficiency. Patients gain immediate, confidential access to contraception. Pharmacists operate at the top of their clinical license, and GPs reclaim appointment slots for patients who genuinely need a doctor's attention. Target 6 proves that expanding healthcare capacity doesn't require conjuring up new resources. It simply requires taking down the walls between the resources we already have.